So my name is Dr. Allison Berky. I am board certified in regenerative medicine, which is a whole new field. And we're kind of on the front lines of working with stem cells, exosomes, peptides, all kinds of regenerative means to whether it's reverse aging or arrest a process that we don't like happening, such as hair loss. So today we're here talking about hair loss because it is one of the most common things we see among aging men and women. And yes, women as well lose hair for different reasons. Androgenic alopecia is typical balding in men, and there's a typical pattern, and I'll go through that as we do the procedure. But whenever you're taking a patient in and looking at their reasons for hair loss, you want to rule everything else out. So you've already talked with the patient, you've explained their options, you've figured out the etiology of their hair loss, because we want to address everything that is causing it. If you miss one piece, you may not get good results. So you want to have a good understanding of your patient. Typically with men, we all think hormones, but for women as well. So number one, hormones play a big factor. Inflammation can play a big factor. If someone is on medications, that can play a big factor. Inflammation can go all the way back to autoimmune disease. It can be post-COVID. We've seen that. There are many reasons the hair might respond and fall out. So when we look at a patient, we look at blood work, so their hormone levels. We might look at inflammatory markers. We would probably look at their medication list and their history. For example, when did they start noticing this hair loss? Where did it start? Are they noticing an increase in it lately? And I go through the understanding of hair loss with them. Hair growth has 3 phases. There's the anagen phase, where you're actively growing, a telogen phase, where you're actively falling out, and in between there's a catagen stage, where things start to slow down from growth, and they can stall in that phase. Some people see hair fall out all at once. Other people notice thinning, thinning, thin. Your classic male pattern balding, which is androgenic alopecia, starts at the hairline. They see it receding along the temples. Then you get thinning along the top, thinning at the crown. DHT is a metabolic product of testosterone, which acts on the hair follicle and tells it to regress, go quiescent, and then dormant and fall out. So cellular therapy now kind of has 2 parts to it. Cellular therapy is stem cell therapy. It is a cellular product. Exosomes are kind of the cargo packets that are carrying all of the growth factors that are released by the stem cells. So now we can actually just deliver the exosomes that have been primed in the lab for hair growth or skin regeneration. In this case, we're going to be using a combination of 2 exosome products. But for any cellular therapy, the goal is that you are going to improve the integrity of the skin. If the skin, especially the scalp, has decreased vascularity, so it's not getting enough blood flow. If there's inflammatory things going on, that can be anything from a tinea capitis, which is a fungal infection, to post-COVID, post-viral infection. Stress can cause it. So there is a big inflammatory component. Nutrient deficiencies can lead to hair loss and changes in the integrity of the hair. So we're looking at all of that when we assess a patient and decide, do we need stem cells? Stem cells will last longer. They are a whole cell. They have DNA. That DNA is not incorporated into the receiving subject's body. It is just the structure of the cell that keeps it producing exosomes for longer. Now we have products where we can take a stem cell, tell it exactly what best exosomes we want it to make, and then put it in the hair or the skin or the joint. So with hair, There's a lot of talk about, do we do it in the telogen, catagen, anagen phase? When do we do it? Anagen, traditionally, we thought, oh, try to catch it when the hair is growing. But now we know it doesn't really matter because over a person's scalp, you have many different phases going on. Depending on the pattern of hair loss you're seeing, that can give you an idea of the etiology of the hair loss. I don't worry now anymore when I'm putting the exosomes or stem cells in, because they're going to start working to decrease that inflammation, to revive the hair follicle if it's still there, and to bring in angiogenesis, which is new blood flow, stimulating more oxygen and nutrients coming in. I'll usually supplement that patient with nutrients if they need it, with vitamins, minerals, things like that. But that's a good question because a lot of people think I have to catch it in the right phase. And we really don't have to do that anymore. Your hair is in many stages at all times. You're asking about whether or not there's any live follicle left to revive. And that really depends on the duration of time they've had that area of alopecia. So alopecia means the absence of hair or hair follicle. So, you can see that, let's say someone had a head trauma and they had surgery and they have a scar and there's no hair follicles left. Well, there's nothing you can do there except transplant new follicles in. If someone has alopecia from an autoimmune disease, if it's been like that for 20 years, highly unlikely any of our products are going to be able to revive that. But if it's fairly recent, within the last year, and depending on the cause, there's good likelihood you can get some growth back. I would not use it in conjunction with a hair transplant. I would try it before, depending on the specific patient. Once you get to hair transplant, that's a major surgery. They're, cutting and moving scalp that has the hair follicles in it and trying to get coverage. And you can get some really good results of that. I think our understanding now of stem cells and exosomes, and we catch it earlier, in any scenario, the sooner you can treat, the better. You're going to get better results because you're catching it at an earlier stage. So I wouldn't combine it necessarily with that. That would be a last resort to do a hair transplant. I would combine it with other things like supplements, nutritional therapy, scalp stimulation, red light therapy, which brings in, blood flow and improves circulation, and oxygen. You can even do hyperbaric oxygen therapy. You can add peptides. That's one of the things I have on my protocol. There's topical peptides and injectable peptides. So we have a lot of tools in our toolbox that we can add depending on what that specific patient needs. So when we're talking exosomes for hair restoration, A, the price is much more affordable. B, you're going to get a product that is directed right towards what you're doing. With stem cells, the cells are able to respond to any inflammation, any injury in the body. So they might move away from the area. They have a chemotactic response, meaning the injured area is sending out chemical signals and the stem cells respond to that. So you may not get them all staying where we want them. The exosomes are happy little campers. We put them in and they just start getting to work. I like administering them with the microneedling device, and we'll get to that, but we're creating a little micro trauma as we needle the scalp, and then they can better do their work. But I think with exosomes, the number one thing is people are looking for results. The number two thing is they're looking for affordability. The number three is they want a good quality product that they trust their doctor to be delivering, that is safe, they don't have to travel to another country to go get it. People that, let's say they recently had chemotherapy or they're actively getting cancer treatment, I would not introduce another substance into their body. These are very benign substances. Even the cellular product, the stem cells, in our consent forms, there is a paragraph that says you can have some type of reaction to it. It is called a transplant because it is coming from a different human body. Our bodies seem to accept it very well because they don't have the immunogenicity of, say, a virus or a bacteria that stimulates our immune system in that way. Another person that might not be a good candidate is if they've had a recent head injury, only because you want the scalp to be in good condition so that it can incorporate all of the growth factors that the exosomes are wanting, the work that they're wanting to do. If they are using actively certain products on their hair, we might have to stop that ahead of time. If they're on certain medications, we might have to stop that ahead of time. But most healthy people are great candidates for this. So I will address with the patient where their status is, what the diagnosis is, why we're seeing the loss of hair that we're seeing. And typically, once I look and see if the loss has progressed to a certain point where I don't see any hair follicles left, I will tell them, I see all the way up to here, we're going to get some regrowth, but after here, probably don't expect any regrowth. Hence, doing it sooner the better. And what they do from the time they get these treatments, and sometimes they need a few to get the best results, what they're putting in their body, the nourishment, the red light therapy, if they're doing that, other topical serums that I recommend in between treatments, all of those put together, you can get a good result in about 9 months. You will start seeing little hair regrowth within 3 to 6 weeks, but you're not going to see good coverage for about 9 months, somewhere between the 6 to 9 month mark. Again, the more loss they've had, the longer it's going to take to start filling in. So Matthew and I have already talked about his pre-treatment, which is pretty simple. He's healthy. He has androgenic alopecia, so that means that it's hormonal hair loss. He doesn't have nutrient deficiencies. He is on testosterone. A lot of men are on testosterone, and that can increase androgenic alopecia if they are producing a lot of DHT. And then we mitigate that in other ways. DHT is not affected by the exosomes. What the exosomes are doing is regulating the scalp environment so that the hair follicle can regenerate, repair, and regrow in a healthy way. A lot of times you get people that are getting some regrowth, but it's very thin hair. It might be easily falling out. It might be sparse. Our goal is to increase the density of the hair, the integrity of the hair, and then the thickness in the areas. In Matthew's case, depending what I see when I start injecting him, if he has some robust bleeding, then I won't be too worried about increasing the blood flow to his scalp. Some patients, they have almost no bleeding, and then I say, I'm concerned about that. Let's improve that while your hair is undergoing the process the exosomes are putting through, teaching the follicle. So they will release their anti-inflammatories, they will turn on growth factors, and they need oxygen and energy in order to regrow a cell. So that's getting into, some people, if they're running, they're increasing their oxygen intake, they're increasing their blood flow, so that would take care of it. Other people might need, say, a hyperbaric oxygen treatment or, additional peptides, other topicals. So it depends on the patient. Preparation is really easy. They just need to be mindful for 24 to 48 hours beforehand of anything that could increase bleeding. So, because I want to kind of see their natural state. So those are anything from, obviously, I'm going to know if they're on a blood thinner. So we would, pull them off that for 24 hours. But Things like aspirin, ibuprofen, which also is Motrin or Advil, nonsteroidal anti-inflammatories, naproxen, alcohol, certain herbs, vitamin E, fish oils to make you bleed more. So for a couple days, we have you stop those. Then we have the patient come in very clean, no products in their hair so they can shampoo that morning. Then I only clean with alcohol. We don't use any numbing cream because we don't want to change the natural environment of the scalp, especially the pH. When you're introducing a biological product, it's happy when it starts to thaw. Here's our product. When it starts to thaw, it's in its happy place. Even if I cleaned off lidocaine and numbing cream, there still might be a little bit that was absorbed in the skin, and now we've changed the microenvironment. So it's an easy prep, and then we just clean with alcohol. And it goes pretty fast once we get going. It doesn't take too long to do, depending on the area, of course, that I'm doing. And then some people tolerate it well, and other people need a little bit of for comfort measures. Yes, if you want good results, you're going to want to look at their nutritional status. You're going to want to look at whether or not they're on hormones or have been. Typical physical exam, make sure they don't have thyroid problems that can add to it. Find out what their recent infection, if they've ever had mono, long COVID, or a recent bad COVID infection. We're seeing a lot of hair loss after that. So yeah, you're taking your basic history and doing a physical. So I use, it's actually an older model, but it's very easy to use. It's called a meso injector or a mesotherapy gun. A lot of times they were using it for other types of aesthetics or veins or anything. But what I like about it is that I can set it to the exact volume that I'm injecting, the depth that I'm injecting, which when we're injecting the scalp, I'll do several passes, and those passes, you want to go initially down to the bottom of the dermis, which is about 0.8 millimeters. Then you're going to pull up to about 0.6, 0.5 millimeters. That's where your hair follicle sits. And then you might do a third pass further up, depending on how brisk they're bleeding. If all your vasculature is in your dermis, but sometimes a third pass, if we have extra product, I'm usually delivering anywhere from zero point 0.1 microliter to zero point 0.5 microliter per injection, and the gun does that for me. This machine has a vacuum, so it's sucking out any other biologic blood products as I go, so that just the injections are the biologically want to put in. I use a sterile needle. This one is a 5-point pin. You can get, they usually come with the machines, but there's all kinds of newer ones now. It's attached here already. I have one attached. And every time it injects, you get a 5-point injection, and each needle will be delivering to that depth the exact dose that I tell it to. First, we'll clean with alcohol. Again, we talked about not using any type of topical product the day of procedure. No hair products, no scalp products, no medicines, and no numbing cream. So what I'm going to do with Matthew, he's a perfect example of androgenic alopecia. So everyone in hair restoration is probably aware that for male pattern balding, we use something called a Norwood scale. The Norwood scale is, it basically describes the pattern of balding so you know where you're starting with your balding. And the first place, a Norwood 1 on the scale, is when a man still has his top hair, but he's noticing here at the hairline. You can see Matthew's hairline probably used to be about here. So that was the front of his hairline when he was younger. So first you start seeing receding here, just above the temporal area, and oftentimes we get this. And some men will stop right there with that type of balding. So that's a Norwood scale of a 1. Then you can start seeing thinning. You can see here that this the quality of this hair and the density of the hair follicles is very different than, say, here. These are normal. That's what he used to be. So here he's already being affected by the alopecia. Here they're thinner, not as healthy, very sparsely located. So now you're getting into a Norwood 2, and some men might just recede back to here, and you see that. So that's the second area that we look at. And then this is called the crown, this whole back area. So this now puts you into a 3 or 4. When you're examining your patient, you're just going to look for areas that might be scarred, that might not respond as well. And here you can see this area through here. He still has much better hair coverage through here than these areas. So in particular, I'm looking right here. I don't see very many hair follicles right here. So we'll see. We'll see after the first treatment at about our 6 to 12 week mark. I'll have a better idea if we're going to be able to get anything back there. I do think here, there are some hair follicles here that we can see. The quality of the hair, though, is not good. And you can see there at different stages of a few follicles trying to break out there. But so we're going to look at depositing the exosomes all through the dermis up to the epidermis, and we'll see how he does. Okay, so when you pull your exosome or stem cell product is going to come directly from the distributor. They've been in a deep freeze, and you're going to pull them into the room and let them thaw at room temperature and use them with your machine. You're going to deliver them right sterilely into the scalp. You can tell when you've got a nice liquid that it will have a little bit of a gelatinous look to it because it has some extracellular matrix and things, hyaluronic acid, things that help support the vitality of the exosomes. You will not see any pinkish color. There's no red blood cells or anything left in these products. If you see that there's still some icy chunks, you just want to wait a little bit longer and let it thaw out before you pull it up. You want to use at least a 23 or 22 gauge needle to pull it into your syringe. And I'm going to mix 2 products here. We have the one for hair, so it's called Exo Hair. Our first little vial here is a 1 cc vial. It is of the exosomes for hair. It's fully thawed. I'm using a 23 gauge needle because they're exosomes. Exosomes are like 50 nanometers at most in size, so they can easily pass through a 23 gauge needle. After we've pulled our product out, we will use a designated vial of normal saline and just rinse the vial to get all the very last exosomes. These exosomes have billions and billions in each cc. It's always nice to make sure if there's any clinging to the side wall that we mix with a little bit of saline and draw it all back up. Once I've done this, I will toss this vial of normal saline so it's not used for any other purpose. Okay, so I just check and make sure there's no ice crystals left or anything that looks abnormal to me. It's not going into an IV, so we don't have to look for particulates or anything like that. But I do look to make sure nothing's going to clog my tiny little needles for injection. You want to make sure you don't lose any product, of course. Okay, so let's talk a little bit about how you're gonna, deliver your exosomes. How do you decide where you are in the scalp? So men always have thicker scalps than women. And, you have your frontalis muscle that comes up here. So some areas will have frontalis muscle all the way up to here. You can ask the patient to raise their eyebrows and you can see how high up that frontalis muscle comes. Good. So in that scenario, if you go too deep, you're going to hit their muscle and it won't hurt, but we want to stay in the dermis. On my eye, this one asked me what viscosity. Exosomes and stem cells are always a very low viscosity. It's going to ask me what size syringe I'm using. And then I'm going to tell it how deep I want to go. I'm first going to go down. I want to go a little bit below the follicle, which is where a lot of your vasculature is, and it's at the base of the dermis. I'm going to go about 1.2 to 1.5 millimeters. And I'm going to give a zero point 0.3 to zero point 0.5 microliter dose, which is delivered through the 5-pin point. And then I will do the speed chew. Now I'm turning on the vacuum that I mentioned, that with any biologic, it's nice to have, this compartment is sealed so that as I'm delivering, there's a suction process. I'm going to start on this side just because you're there with the camera. So I'm going to come here in between this first area. There's no point. You can see here, he has no hair follicles here. If, let's say, a patient was losing further down, you can come further down, but you're going to start right at the edge of where their hair loss is. And in particular, I'm going to really focus here because we see some good hair follicles there they're just struggling. So we're going to give them a little help. Now, if you could turn your head to the right for me. Good. Okay, so this is what it sounds like and feels like. Turn a little more. Thank you for my shoulder. So you're achieving pressure with this gun because of the vacuum. That's the worst that it's going to be unless I hit a more sensitive area. Now you can see with that first injection, I'm not seeing any pinpoint bleeding. So part of the problem going on in his scalp is that he is not having a good amount of blood flow. For patients like this, I like them to be doing red light therapy. There's certain ones that are good and bad. There we got some good blood flow. And then I also like these patients to use what's called a scalp massager. And that just, feels good for one, but it also, any type of massage brings in blood flow. If you want to come and see, you can tell from the pressure that this box is putting, you can see where the needles are going in and where the device is actually touching. So I'll come back through at a different angle, say maybe here, and I'll come through the middle of my grid. So as I came further back to where we see some viability of the hair, we're getting better blood flow. And this is why I don't want people on blood thinners or taking a bunch of aspirin or ibuprofen. Believe it or not, Chinese herbs can really make people bruise and bleed. So as I come back, the scalp gets thicker. So I'm going a little bit deeper as I come backwards here. Anything close to the forehead is very thin. You don't need to go more than 1 or 1.2 millimeter for your first pass. You just holler if it hurts. If anything drips out a little bit, I just go right over that and push it in again with the needles. So you're making a little, like a microneedling micro trauma that delivers the product, but also stimulates the scalp to start its own healing process. For hair, I've moved completely to exosomes so that I can deliver it in this way. And now we have exosomes that are targeted right for hair repair, growth, restructuring of the follicle. Sometimes the follicle, a big question I get is, well, how do I know if it's gone for good? And we don't always know. It depends how long that follicle's been dormant and the cause, of course, of why it went quiescent. But back to the point I was making up here, we know that you may have had hair there when you were young, but there's no hair there left. So afterwards, I also recommend people, if they're a little sore, which, tonight some people feel a little bit raw or sore, a little bit of swelling, you can put a little ice on it if it's really hurting, or a little Tylenol, but nothing else. All the other painkillers aren't really needed. And then anti-inflammatories, of course, we don't want to knock down the response that we're trying to achieve with the exosomes. But you can see back through the top part of his scalp where he still has hair, there is a nice robust response. We're getting bleeding. I like to see that. So I've gone about halfway through. So in the important targeted areas, I'll come back through a second time at a little bit shallower depth. So we're basically bathing the hair follicle, the blood vessels, everything there in the dermis, which is in the bottom half of the dermis, with the exosomes. So after exosome delivery, patients should not ever feel any type of itching, allergic reaction, dizziness. This is a very superficial injection. It doesn't move systemically. It will stay and do its job here. It is not an immunogenic product. It doesn't create some sort of reaction that even a basic antibiotic would. It's not a transfusion or blood product. And the exosomes themselves are packets of growth factors that have been produced by a stem cell. In this case, this product, they came from umbilical cord stem cells, mesenchymal stem cells. The fact that it's just basically like PRP, but from umbilical cord, is very important because it's not a cellular product. There's no risk of a bad reaction. So PRP is drawn from your own blood. PRP is a blood product that we've drawn the patient's blood and spun it down in a centrifuge, separated out the red blood cells. And the platelets carry a lot of these very growth factors and the richness in the blood. The problem is that that's from that patient. So if there are mitigating factors in their PRP that are adding to their hair loss, you're still getting it in that PRP. This is a completely separate product from a separate source, and it's purified and intensified. So you're getting billions, hundreds of billions of these little exosomes, whereas with PRP, you're probably getting less than half of that. The other good thing is they are removed from the original source. I was saying that the cellular therapy with stem cells does have a cell structure. It has a DNA and RNA, and those cells can move around and respond in the body to other things. The exosomes are going to just stay put right where we inject them. I mean, there is some blood flow, but they're going to go to work. It is technically, it's a semi-sterile procedure. Like I've cleaned with alcohol, but the needles are sterile, but you don't need a sterile room and sterile gloves. This is all utilizing the injectable, just like when people get Botox or something. The product is sterile and we clean the skin, but then we deliver the sterile product. My feeling about hair transplant is that it can look really good for a while, but if you're not treating the cause of hair loss, they're going to end up with more hair loss. So this in combination with addressing the true etiology, then you can get the best results and the longest lasting results. Is that hurting? No, not too bad. About the same. All right. So I'm going to, for the last bit here, I'm going to have you turn onto your right side. You can even turn onto your right shoulder a little bit so I can get down here. Perfect. Thank you. This is sort of where the hairs are starting to show that they're in trouble. All through here. And what we typically see if and when we start to get the hair regrow, it will regrow in the way that it fell out. So it'll come back here first, and then we might have to do another treatment here, and then it slowly fills in this way. Mm-hmm. Shaving or cuts don't affect the follicle. Sometimes I'll go through with people what shampoos they're using, what else other products they're putting on their hair. Women, get them to stop coloring, just to let the follicle rest and repair and regrow. The things that can be harmful to the hair, what is it, sodium dimethylated. I can show you afterwards. There's a couple things that are in like every toothpaste and every shampoo. So I do recommend a few. There are some now made by like the Hims and the Hers and all of that. Basically, those are just tea tree oil and other gentle cleansers for the hair. Almost done with this part. I'm going to change my depth and do a second pass on a few of the most affected areas. This part can hurt the most because it's right along that. Okay, last few here. Let me just go over quick with one more wipe and we're done. Most importantly, know that there's been a little bit of trauma introduced to the scalp, so it can have a little bit of swelling, a little bit of soreness, and we made micro openings, so we want those to close over. There's a lot of little kind of pinpoint bleeding that will scab, and that will come off in the shower tonight or tomorrow without any need to scrub. But those do help the little pinpoint needle markings to close and hold the exosomes in. And then in any scenario, whether it's an IV or any new treatment, if they feel weird or anything looks red, swollen, they're supposed to contact their physician immediately. I've never seen that happen, for 10 years. As far as care, you want to keep products off for 48 to 72 hours. You can just use water to get any, like he has a conference to go to, so he can rinse and kind of gently wipe with a towel or cloth and make sure all these little pinpoint scabs are gone tomorrow. And then let it do its trick. And then I do pictures again in 12 weeks. Typically, I say, wait till you see that these scabs have closed up and healed. So usually that's 1 to 2 days. And then they're fine to wear hats. Worst case scenario, you go out on a boat or something, wear a hat, or if you have to put sunscreen, don't wear it for too long and wash it off.